by Chinese Critical Care Ultrasound Study Group. I'm Dr. Yanggong Chao from the Department of Critical Care Medicine, the first hospital of Tsinghua University, Beijing. And I am the Executive Director of Chinese Critical Care Ultrasound Study Group. It's my honor to be one of the moderators today. As you all know, SARS-CoV-2 virus transmission has now become a major threat to human beings. Nearly 20% of critically ill patients need timely and accurate treatment to save lives. In such a situation, it's important to visualize the monitoring and evaluation tool. Critical care ultrasound has acquired more and more attention from our medical colleagues. In the process of fighting against the pandemic, the expert of CCUSG fully summarized the clinical experience, published our own experts' consensus, and held an online course to share with all of our colleagues, friends, and audience. In the past weeks, we have systemically introduced the application experience of our critical care ultrasound in the diagnosis, monitoring, and treatment of COVID-19, and also received positive feedback and welcome from many international peers. After a series of courses, today will be our last one. Because of these reasons, we invite some speakers before give us a lot of experience, some course together today. And we also invite the last speaker is another Executive Director of CCUSG, Professor Xiaoting Wang, and join us and give us a very important, very interesting topic. So it's the end of the course, but we truly hope that it's also a beginning of our cooperation with international colleagues to overcome the pandemic. And today, and not only me as a moderator, and also we have a very beautiful lady as Professor Zhu Ren as the other moderator. So I give the speaker microphone to her. Zhu Ren, please.
Thank you, Professor Chao. I'd like to introduce myself. I'm Dr. Zhu Ren. You can call me Dr. Zhu. I'm an ICU attending working in the first affiliated hospital of China Medical University in northeastern China. I'm Deputy Director of our department, also Vice Chair of CCUSG. I'm delighted to be here again in the webinar as a co-moderator. I have been combating with COVID-19 until late March, and I will be glad to answer any of the questions from the audience within my capability. That's all. Thank you, Professor Chao.
Okay, I think it's time to invite our very important speaker today, Dr. Xiaoting Wang. Xiaoting, it's your turn now, please.
Hi, everyone online on our webinar. Good night. I say hello to everyone, especially ICU doctor and nurse. Every practitioner is in the front line of fighting the COVID-19. So as we all know, COVID-19 become worse and worse in all over the world, especially outside of China, from the epidemic to the pandemic. So I'm Professor Wang Xiaoting. I come from Beijing. I work at the Peking Uni Medical College Hospital. I'm an ICU doctor. Today, my lecture's topic is the principles of critical ultrasound practice in critical COVID-19 patients. It's the last course of our series course. But I think the last one, but not the least, I maybe take a little summarize of the totally completed the series course. I hope to help everyone, help you, help me, help us to fight the COVID-19 patients. So There's two stars. One star is a political star. His name is Boris Johnson. He's Prime Minister of UK. He got, unfortunately, he got COVID-19. He is a COVID-19 patient. There's good news come from UK yesterday night. Johnson become better and leave the hospital, but I think his famous scene. I think I think I will share this famous thing that together we will overcome this challenge, as we have overcome so many challenges in the past. It's a very, very good wish. It's a very, very good hope. So there's another star. He's an ICU doctor. It's a Europe famous ICU doctor. He gave us lots of advice, lots of thoughts to help us to treatment and diagnosis and know the COVID-19 patients. He has a famous saying about the COVID-19 patients too. Like that this is a kind of disease in which you don't have to follow the protocol. You have to follow the physiology. Gattinoni said. Maybe I think the protocol are like a guideline and some fixed protocol, and that's deleterious. So Gattinoni said, the famous thing is very important for us. Unfortunately, many doctors around the world cannot think outside the guideline, outside the fixed protocol. So other experts totally agree with him. Just like some experts said, if you over-distend somebody's lung on mechanical ventilations, you essentially generate more ARDS. You make the lung leak. His name is Bo. So these two famous doctors has two famous things. Maybe give us lots of thoughts, lots of knowledge of COVID-19 patients. Oh, okay. How can we do what we would like to do? So in the past 2 months, maybe in the very beginning of COVID-19 patients, COVID-19's epidemics in China, we organized lots of frontier, lots of experts, lots of ICU doctors, my colleagues in the front of Beijing, Wuhan, China, and we published a paper, published recommendations for treatment of critical COVID-19 patients based on critical ultrasound. It's our work, it's our job. We have the same wish, we have the same hope as the Premier Minister, as Europe ICU doctors. So just like what's mean in our recommendations, our census paper. How about critical COVID-19? How about what's the features of critical COVID-19 patients? At first, I will tell everyone there's about 10% of the COVID-19 patients can worsen to critical COVID-19, critical. So if the patients become critical, become a critical illness, the feature of clinical manifestation is as follows. Just like the first one is continuous aggravation of pulmonary lesion and injury after virus invasion. And the second one, the second step is early onset of severe respiratory failure, hypoxemia. It's very, very severe. And then secondary condition of circulation deteriorate and multi-organ injury. That's the 3 key features. It's important features of critical COVID-19 patients. So In pathophysiology views, we will see maybe these patients maybe got at the first oxygen delivered organs, just like lung and heart injury, lung and heart dysfunction, and then combined sequentially combined oxygen consuming organs injury, just like brain, kidney, liver, intestinal, skeletal muscle, etc. So in depth, know it, do it, how to do it. We need to follow the principle based on physiology. So we have 10 principles. First one is in-depth understanding lung ultrasound based on lung anatomy and COVID-19 pathology. It's very important. So we will in-depth understanding lung ultrasound. So just like in the first view, in the first aspect, we maybe study the lung anatomy and to know the longer ultrasound view. Just like we maybe think anatomy, the lung is from the pulmonary lobe to pulmonary lobular, and then to respiratory lobulars, and then to alveolar, from big to little, from up to lower. And the first one, the first thing I want to tell us, it's a very important distance. We will know. We need to know some distance. The first one is just like pulmonary lobular. The distance is 0.5 to 2 centimeter. Just like and then the respiratory lobulars, the distance is 7 to 8 millimeter, and then alveolar, the distance of alveolar is 0.2 millimeter. So there's three distance about the lung anatomy. What's the correlation with the longer ultrasound? Let's see. Let's take a look. Just like B7 line, it's just like respiratory lobular, because respiratory lobular, the distance is 7 to 8 millimeter, and then if the water if the lesion progressing, water infiltrate and fluid leakage, and then the fibrosis become worse and worse. We can see B3 line, and get worse and worse. We can see diffused B line. So it's have a strong correlation with the lung and anatomy, just like respiratory lobular is the distance is 7 to 8, just like a B7. And then we can see another view, just like this. As we all know, just like what I mentioned just now, pulmonary lobular, the distance of a pulmonary lobular is 0.5 to 2 centimeter. So we can see the lung ultrasound, the shared sign, just like this. Maybe if this little consolidation, little lesion is less than 2 centimeter, so I take a name for this, shared sign. It's a lung ultrasound, a standard view. So the next, if the consolidation of the lesion, consolidation become bigger and extension about 2 centimeter, just like we maybe give it a name, gives termination, lung consolidations. So we can see infiltration aggravates water and anything. So from the red sand to lung consolidation, it's the first aspect. So we can see pathology and physiology of virus and bacterial pneumonia, sepsis, lung injury. What's the difference? We can see these slides. We can see if the patient got bacterial sepsis, so the injury targeted cell is intestinal endocellular cell. So you can see rapid intestinal exudation and then alveolar exudation, and then patient got severe clinical manifestation, just like hypoxemia, dyspnea. If we give lots of improper treatment for the patient, just like improper respiratory and circulatory intervention, so the patient maybe get some secondary lung injury. Then mainly epithelial and secondary endothelial may be combined, epithelial plus endothelial, and then patient got a very, very severe condition, just like gravity dependence change of lung, just like consolidation and gravity dependent. Okay, if the patient got a virus pneumonia, so in the very beginning, the injury cell is alveolar epithelial cells. It's the target cell, and then rapid alveolar exudation progressive. If the patient got worse and maybe got a pulmonary intestinal exudation, and the same patient got a severe hypopnea, severe dyspnea, and combined with improper respiratory and circulatory intervention, and then patient got circulatory lung injury, and now patient maybe the target cell from epithelial cell to endocellular cell. So maybe patient in the later stage, patient got a gravity dependent change of lung, including gravity dependent consolidation and gravity dependent infiltration. So that's all. It's very important. And then, so we can see some pathology in the very beginning. In the early stage of pathology of COVID-19, it's alveolar epithelial cell injury. You can see atrophy of shedding and alveolar epithelium, and type 2 pulmonary cell hyperplasia, and then protein-like exudation with glutein, and scattered protein-like global bodies. So maybe sometime you can see fibrin mononuclear and multinuclear dense cells in alveolar. So then in the later stage, in the progressive stage especially, not in the very late stage. In the progressive stage, a patient of COVID is key point is that capillary endocellular cell injury from the epithelial cell injury to capillary endocellular injury. You can see lots of special signs, like diffuse intra-alveolar hemorrhage and partial alveolar wall rupture, and the important sign is in area of severe hemorrhage, alveolar walls disintegrate and coagular necrosis occurs. So its reason focused on capillary endocellular cell injury. It's the key key features of the pathology from the early stage to the progressive stage, and sometimes you can see some in the last stage of pathology, just like a fibrin to the interstitial. So how can we, based on the pathology, how can we find some special findings of the COVID-19 patients longer ultrasound? Just like in the very beginning, you can see the vascular shadow is thickened and the interlobed fiber is obvious, and you can see some special sign in the CT scan, just like a ground glass shadow, GGO, and enhanced vascular shadow. In longer ultrasound, you can see B7 line and the pleural changes, and the lesion is focal, and then you can see the B7 line, and then the patient's the pathology, the patient's injury, patient's lesion progressive. You can see multiple ground glass shadows. You can see larger area multiple ground glass shadow, maybe large area GGO. You can see diffused ground glass shadow. Sometimes you can, in the very beginning, you can see some special sign and A to B alteration. A line to B line and B line to A line alteration, and between inspiration and expiration during the respiration. So it's very, very important, very, very special. Just like you can see A to B alteration and B to A alteration. If the patient continue to progress, we can see lots of muscle excited shadow. Maybe you can see in the long ultrasound view B3 line and the pleural changes. So you can, if the patient continues to progress, you can see large inverted shadow and diffuse infiltration. This sign, this infiltration shadow, sometimes gravity dependence, sometimes non-gravity dependence. It has different meanings. So we can take a next slide. Sometimes you can see small consolidation. In this small consolidation, you can find air broncho sign, and you can see some small infiltration noodle. So in long ultrasound view, you can see shared sign. This sign, this lesion, maybe in the very beginning, maybe in the all duration of the COVID-19 patient's lung. So then progressive, you can see some muscle consolidation, and you can see tissue-like sign. You can see air bronchogram and in different region. So this consolidation, especially muscle consolidation, have two features. Sometimes is non-gravity dependence. It's its reason often is Weizer's injury, Weizer's pneumonia, and then sometimes more muscle consolidation manifestation in CT scan, in longer ultrasound, is gravity dependence. Maybe its reason most like just like ARDS, just like the lung injury, the secondary lung injury. Okay, it's based on Panzer logic. In the during the totally proceeding of the COVID-19 patient's lung, but in the last stage, maybe some patients become better and better. Some patients absorbs totally. So no anything less left. So, but some patients got to fibrosis stage from we can see some focal fibrosis and extensive fibrosis and diffuse fibrosis. So we can see through this longer ultrasound view, we can see irregular pleural thickening and unequal B-line spacing where the distribution is fibrosis feature. So in a little conclusion, disease progress in severe, in critical COVID-19 with lung images. How about the lung images? Just like in the very beginning, pleural be involved, pleural be affected. We can see the pleural from thickening alteration to combined with inconsistency and restricted movements. And then longer ultrasound view, longer ultrasound findings progressive of infiltration of the exudation, just from GGO to exudation to infiltration. And we can see lots of special signs in the longer ultrasound view, just like B2A, A to B alteration in respiration from inspiration and expiration. And then you can see focal B7 line and multiple B7 line and multiple B3 line and diffuse B3 line and B fusion. If the patient got worse and progressive, you can see lots of consolidation from red sign and to tissue sign to diffuse tissue sign to consolidation. And then, and if the patient can go to the last stage, you can see lots of fibrosis features of the CT scan of the longer ultrasound. Just like in the lung ultrasound, we can see thickening, inconsistent restricted movement and focal irregular B-line and diffuse irregular B-line. It's fibrosis stages, lung ultrasound features. Oh, okay. We published a letter, published a paper, a letter in a famous magazine publication. Its name's Intensive Care Medicine. Paper's name is Findings of Lung Ultrasound of Novel Coronavirus Pneumonia During the Epidemic. So in this paper, we take a conclusion of the lung ultrasound of the COVID-19 patients, especially critical COVID-19 patients. They're like as follows. Second, the pleural line, B lines, multifocal, discrete, and confluent B lines from small consolidation, red sign, to non-transport and translobar consolidation, maybe massive consolidation. And then we find the pleural effusion is rare. And there multi-lobar distribution of abnormalities. So we will emphasize that focal B line is the main feature in the early stage and in the mild infection. Alveolar interstitial syndrome is the main feature in the progressive stage, and in critical ill patients, A line can be found in the convalescence. Pleural line thickening with uneven B lines can be seen in patients with this pulmonary fibrosis. Okay, it's the first principle, and then we have the second principle. In-depth understanding the lung injury of COVID-19's primary and secondary. This it's describe about the pathophysiology of COVID-19 from type 1 respiratory failure to classic ARDS. You can see what I mentioned just now. It's from the epicellular muscle cell injury to endothelial cell injury. So you can see the lesion from the lesion CT scan and the lung ultrasound maybe show us the ground glass, the opacity to extravasation to infiltration and to consolidation. So maybe in the last stage, it's fibrosis. Its pathophysiology manifestation is diffuse dysfunction of oxygen and the lung volume reduction and the lung compliance reduction and the VQ mismatch. So I take a little conclusion about this. Pathophysiology of COVID-19 from type 1 respiratory failure to classic ARDS. It's from the primary injury to secondary injury. Just as what I mentioned, maybe the classic ARDS it's keep on. It's maybe a point. It's a secondary injury. And then what's the exact detail? Just like in the very beginning, it's a primary injury. Just like that is to say primary virus injury. Its reason is epicellular injury and excellular date, and combined with pulmonary vascular resistance. And then secondary injury. The first secondary injury is secondary compensatory injury. Just like first one, respiratory drive is very strong, and the sympathetic activation, and the manifestation is the hyperdynamic heart, and then progressive to microcirculation endocellular injury. So the secondary lung injury is secondary therapeutic injury, just like based on the microcirculation endocellular injury. We take a lot of inappropriate circulatory and ventilatory treatment for the patient, just like first one, inappropriate fluid management, lots of fluid overload, and makes the lung worse and worse, makes the lung edema worse and worse, and sometimes ventilatory associated injury become worse and worse because you give lots of improper ventilatory strategy, improper ventilator setting, and then sometimes maybe the patient got subsequent infection. It's a primary injury, and it's the difference. It's a progressive. It's a proceeding primary injury and secondary injury. In the very beginning, it's a primary injury only. It's only primary injury, and then developed with secondary injury, and then primary injury combined with secondary injury makes the patient become worse and worse. So, and then let's take a look some primary injury in the lung ultrasound, from GGO to extravasation, infiltrate, shared sign, and sometimes pleural thickening, like multiple ground glass shadows and diffuse ground glass shadows and large air multiple ground glass and GGO, lots of is GGO sign. And then you can see muscle exudative shadow and progressive. Then progressive to the large infiltration shadow. And then the patient just like almost consolidation, because from the exudation to infiltration, almost consolidation, but sometimes non-gravity dependence, just like this. If the patient got worse and worse, but maybe in the very beginning, with lots of patients have the small consolidation. So maybe some small inflated nodules in lung ultrasound. Lots of patients combined with exist red shine, and then let's take a look. Secondary injury. In Chinese, 白肺. In English is white lung. Lung ultrasound is a specific lung ultrasound sign, just like diffuse infiltration. The first sign, the first lung ultrasound, but its feature. We emphasize its the tendency of gravity dependence, diffuse infiltration, and then the secondary, the standard, the important, the secondary lung injury is consolidation. It's gravity dependence consolidation. It's a classical sign of ARDS. So you can see in lung ultrasound view, we can see A line, B line, and consolidation. We maybe in brief, it's A, B, C coexist. And then why the lung got injury? Just like this. Because there's three key points. One is bigger face area, alveolar, type 1 or 2 epithelial cells. And then the second point, covered with plenty of capillary network, endothelium, just like inflammation. And the third one is the huge blood flow, because the flow of the whole body passes through, just like the cardiac output. Totally of cardiac output passes through the lung. So the lung is easy to get injury. It's the exact reason. Okay, we can give an example for the secondary injury reason. It's the strong respiratory drive. As we all know, there's 4 factors. The first one is inflammatory input, and then the second one is biochemical input, just like hypoxemia and carbon oxygen 2, and the second one is mechanical input, and the third one, the last one but not the least, is the supraponitine input. There's 4 factors. There's 4 input to make the neural respiratory drive strong, and then the patient got a self-inflicted lung injury. Just like in the very beginning, maybe in the very beginning, patient got a lung injury. Maybe in the COVID-19 patients, in the very beginning, it's virus injury. It's the epithelial injury, epithelial cell injury in the very beginning. And then, if the patient got hypoxemia, and then patient have a very increased respiratory drive, and the patient have got a transpulmonary pressure high, transvascular pressure high, and then makes the lung injury, and then makes the capillary leak, and then lung edema become worse and worse. Patient got self-inflicted lung injury. In brief, SILI. It's very important. If we take a diagram ultrasound for a patient, we can see a diagram displacement, and just like this, and then we can see another diagram sign, diagram ultrasound sonic sign, just like a diagram thickening fraction. These two diaphragm ultrasound sign can give us lots of information about the respiratory drive is weak, and the middle is normal, and is strong. It's very important for us. It's important too. And we I would like to tell you, understanding the lung insult in COVID-19, its need correctly. Just like early stage epithelial cell damage, intestinum, and then alveolar and hypoxia, and then respiratory failure. We can see it. We can give it a name. ARDS mimics in longer ultrasound. A-line, B-line ultrasound lung interstitial syndrome, and then sometimes subpleural small consolidation. And in the advanced stage, endocellular cell involved, vasculature, and the whole lung unit tissue, and the patient got hypoxemia and respiratory failure, more like a classic ARDS. In lung ultrasound view, we can find some findings about white lung tendency of gravity dependence, and sometimes gravity gradient A, B, C, and sometimes combined with lots of massive consolidation. And then there's the third perception is in-depth understanding the difference between the virus pneumonia and the bacterial pneumonia. Both could progress to ARDS. In the first slides about this theme, we can see virus pneumonia. You can see consolidation is very, very rare. So you in the long, you can take a longer examination for the patient. You can find lots of B-line view in the whole lung. So maybe in the partial, total, and the focal, local B-line. And there's a key point about consolidation is very rare. And there, in this part, the second slides can take a look about the classic bacterial pneumonia. Pulmonary consolidation is often. It's very different from the virus pneumonia. Just like you can see massive consolidation in the CT scan, and in longer ultrasound view, you can see tissue-like consolidation and the dynamic air bronchogram. It's a longer consolidation sign in longer ultrasound. It's very, very different. B-line to the consolidation, B to C, it's very different. It's a difference between the virus pneumonia and the classic bacterial pneumonia. And there, and here, we will tell you about both of the pneumonia, whether virus pneumonia or bacterial pneumonia. Both of these could progress to ARDS. We can see bacterial pneumonia. From the pneumonia to the ARDS, we can see this CT scan. You can see in the upper lobar, you can see consolidation. It's the primary injury about the bacteria pneumonia, and then you can see after this massive consolidation and lots of consolidation, and it's gravity dependent consolidation. It's a secondary injury. It's the main reason about ventilatory injury combined with the circulatory injury. It's a secondary injury. So this is through this CT scan, we can see patients got a lesion from the primary injury of pneumonia to the ARDS lung injury. It's very important understanding this meaning. And then, just like this slide show us, it's the CT scan compared with the longer ultrasound. it's very, very clearly about for the patients the uneven lesion about ARDS. Just like this one, in the lower part of the lung, you can see consolidation, and from lower to the upper lung, lower of the lung, you can see from B3 diffusion B line to B7 line and to A line, and often combined the pleural alteration. It's the third principle. We may be understanding the difference between the bacterial pneumonia and virus pneumonia, and we concluded that we emphasized that both of pneumonia can develop to the ARDS. So we have the fourth principle is pay more attention to the heart features in critical COVID-19 patients. It's just like we published another paper in critical care, another famous publication company. Its name is using echocardiography to guide the treatment of novel coronavirus COVID-19 patient pneumonia. It's a diagram of just like this echocardiography features of COVID-19 patient pneumonia. It's included four signs like hyperdynamic cardiac function and acute stress-induced tachycardia cardiomyopathy, and the third one is right ventricle enlargement and acute pulmonary hypertension, and the last one is diffuse myocardial inhibition. And let's take a look. Just like as we all know, as the ICU doctor knows, heart is important of oxygen transport. So we need to pay more attention to the echocardiography's role in the diagnosis and the management of the COVID-19 patients. We maybe need to take an echocardiography examination timely, routinely, in the all-timely timeline of the COVID-19 patients. So we can take a look, lots of special features of echocardiography. The first one is a hyperdynamic of the whole heart, including right and left and the ventricle. And then the stress, we can see this one, just like this. And in the apical movement is weak, and in the base of the left ventricle, it's very, very strong. It's very, very active. And then the third one is acute pulmonary, just like acute right ventricle dysfunction. You can see right ventricle enlarged, is very enlargement. And then the last one is hypo, totally, whole heart, right and left heart, and totally is hypodynamic. It's the third. But I would like to tell everyone, mixed is often just like this. Right ventricle enlarged, and the left ventricle and hyperdynamic, and I want to see mixed is common, is often, is common, just like this. Right ventricle is enlarged, and the left ventricle is hypodynamic. So mixed is often, mixed is common. And then we have the fifth principle, just like what I want to say, early identify and evaluation of critical events, and then early thought and early stratification of COVID-19 patients. As we all know, critical events in COVID-19 patients, what's mean of critical events in COVID-19 patients? It's the moment of suspension, the moment of events before the death of COVID-19. It's this is called critical events in COVID-19 patients. It's often have classical critical events. Just like first one is respiratory critical and circulatory failure. So it's the clinical scenario. These two clinical events, these two critical scenario is very, very often in the COVID-19 patients. And then, as we all know, there are no sudden accidents. Only accidents be detected suddenly. So it's a famous thing in critical care. And then what can we do? We can take a critical ultrasound for the patients, timely, often, routine. It can detecting critical events. If the patients got a clinical problem, just like dyspnea, a mild dyspnea, a severe dyspnea, the patient got a hypoxia, and the patient got a circulatory instability and has a clinical hypoperfusion, and we maybe take a critical ultrasound examination for the patients timely. And it's the protocol is what the Professor Ming take a lecture for us in the past week, in the past month. So it's very, very exact, it's very, very detailed. And then we have the approach to evaluation this critical ultrasound examination. We maybe take a conclusion, take a diagnosis for the patient. It's a respiratory, maybe it's a respiratory failure, maybe it's a shock. So then ICU admission for the patients and give the correct treatment for the patient. So critical ultrasound examination is very important to in detecting critical scenario, critical events in COVID-19 patients. And we emphasize then the second one, early thought and early stratification of COVID-19 patients. The patients admitted in ICU in the very beginning, early screening, using critical ultrasound or using critical ultrasound, combine the clinical sign and plus CT scan and plus critical ultrasound examination, we can early stratification of COVID-19 patients, especially severe critical COVID-19 patients. And just like this, 1, 2, 3, 4, 5, and the others. The emphasis, the first one is respiratory failure, and the second one is respiratory failure combined with the circulatory unstable, and then the third stratification is respiratory failure plus shock, and then the fourth is respiratory failure plus shock plus MODS excluded heart and lung, and the 5 degree it's respiratory plus cardiac arrest plus CPR, and then sometimes just pneumonia plus MODS. And then if we take a early screening for the patient admitted in ICU in the very beginning, we can early sort and stratification of the COVID-19 patients. So then we have the sixth principle. It's adhere to lung protective ventilation strategy based on using critical ultrasound. We can take a brief introduce it. Just like a lung protective ventilation strategy, including 4 parts. The first part is low tidal volume and optimal and lower pressure of plantal pressure. And then the second part is prone precision ventilation and then give the patient optimal PEEP. Maybe in some time we need a lower PEEP, not the very higher. It's very deleterious, a higher PEEP in COVID-19 patients, especially in the very beginning. In the later stage, patients go combined with the classical ARDS, maybe the higher optimal PEEP is very important for this patient. And the third part is keep the patient respiratory stable and avoid abnormal respiratory drive, and then avoid the target is to avoid the ventilator-induced injury and SILI. It's a strong respiratory injury makes the patient's lung injury. And then, for example, especially we can see lung ultrasound play a great role in the management of prone pressure ventilator, just like this. Patients from the supine position to the prone pressure ventilation, we can see the CT scan manifestation just like this, and then longer ultrasound examination manifestation just like this. So it's convenient, it's timely, it's non-invasive. It's very, very important. So then we have the seventh principle. It adheres to lung protected circulatory management strategy based on critical ultrasound application. It's just like these slides tell us, critical ultrasound and circulatory management in ARDS. Just like we take a critical ultrasonography examination for a patient, we can acquire lots of information about the volume, cardiac feature, and the pulmonary feature. So you can give the patient proper cell therapy, proper treatment, just like volume. This is treatment include volume administration and fluid selection, and low cardiac output management, and hypermetabolism, sedation, hypothermia, and there we can make a great decision and give us lots of help to because we take a timely and appropriate and correct critical ultrasound examination for the patients, especially the patients got a very severe hypopnea and have a severe ARDS. We can and we realized the targets about decrease pulmonary flow and decrease left atrial pressure, and then decrease exudation. It's very, very important. And then we have the eighth principle. Combined with shock in COVID-19 patients, critical ultrasound is mandatory. As we all know, shock and COVID-19 have a greater relationship. Just like shock is the most severe hemodynamic disorder, and shock makes shocks the pathophysiology. Manifestation is through center circulation to microcirculation, and then shock is the hemodynamic syndrome caused by clinical disease and worsening independent of the origin disease. So we will emphasize that shock is rare in early stage in COVID-19 patients, and blood pressure drops after intubation and deeper sedation. It's important reason for the lower BP blood pressure drops, and septic shock or other type happened in later course. It's a bad news. It's a bad news for every patient, for every ICU doctors. And then how the critical ultrasound play a role in the shock diagnosis, shock management, maybe shock and acute circulatory failure in the early warning and salvage and early identify shock time and directed the shock therapy. So in the whole proceeding of shock, critical ultrasound play a great role everywhere. So we can conclude the critical ultrasound is mandatory in shock management. And then if the patient needs hemodynamic therapy, we emphasize the critical ultrasound play a great role in the hemodynamic therapy, because clinical hemodynamic therapy is a goal-oriented and quantitative process of therapy. According to hemodynamic therapy, real-time assessments and responses to the therapy. Just like what we can take a look about this diagram, we can see if we take a critical ultrasound, especially echocardiography for the shock patients, for the patients needed hemodynamic therapy, we can see the vein, the IVC, the right ventricle, the lung, the left ventricle, the artery, and the maybe sometimes the tissue microcirculation. So critical ultrasound, especially echocardiograph sound, play a great role in the hemodynamic therapy. And then we published another paper, just like what I mentioned just now. It's using echocardiography to guide the treatment of COVID-19 patients, especially pneumonia patients. We can give a conclusion just in the first, as the important part of critical ultrasound. Echocardiography is a useful tool for the fast screen of circulatory status, identifying types of the shock, monitoring during the respiratory and hemodynamic management, and guiding the treatment of COVID-19 pneumonia patients, which is especially feasible, convenient, and advantageous in critical ill patients. So the second, if necessary, hemodynamic manager can follow the 5P principle. It's my idea. Lowers is my team's idea. The first P, lower central venous pressure, optimize the pulse hit heart rate, appropriate pump function, and blood pressure, and organ perfusion as the final goal. It's the 5P principle for hemodynamic management for the shock patients. And then we have the ninth principle. Ultrasound is mandatory during performing ECMO in critical COVID-19 patients. As well as echo in critical illness, it's the mainstay of the modern intensive care medicine, is to guarantee the function of the cardiorespiratory system. ECMO represents nowadays the only therapy capable of completely replacing these vital functions. So we will take some summation about the ECMO in critical COVID-19 patients. The basics is because patients got a severe respiratory failure and the patient is easily to got and acute core pulmonary ACP, and the patient easily to got respiratory support, and we maybe persist this principle, protection first. So maybe we emphasize the significance of ECMO in critical COVID-19 patients, and I think ECMO decision is very, very difficult, and we want to emphasize the effect of ultrasound in ECMO management is very great. And then in the very beginning, in the past years, lots of ICU doctors, lots of experts emphasize that selected physicians on the ECMO team should be trained in vascular Doppler echocardiography and cardiac echocardiography for insertion, maintenance, and surveillance of the ECMO device when needed. So it's a key point for everyone. So recently, some experts in the fourth annual ISO SWAC conference proceeding, they got a conclusion about echo is mandatory during the initiation of ECMO and during when lots of. So maybe take a conclusion for everyone. Echo is mandatory during the echo support. And then in our consensus, we published the consensus in 2016 in critical ultrasound, and then we highlight ultrasound is mandatory during performing ECMO in critical COVID-19 patients. So in the very beginning, we find this importance of the critical ultrasound in performing echo support. And there's the last principle, but the last one not the least. It's principles of critical ultrasound protocol selection. The principle is goal orientation based on clinical problem. Just like these slides want to tell us. We can find a clinical problem. Just like acute onset of cardiovascular collapse, we can find hemodynamic failure, just like shock. It's very often in COVID-19 patients. It's hypoxemic respiratory failure. So we take a critical ultrasound examination in the very beginning. It's a longer ultrasound first, just like 8 room and just like 12 room and 28 room and the protocol for the patients. So just like these slides tell us, the 8 rooms focus on pulmonary interstitial syndrome, and the 12 rows, the protocol used for whole lesion distribution and scoring, and then the 28 rows protocol used for intact interstitial distribution and B-line scoring. So every protocol have different rule in the everywhere based on the clinical problem. And there, in the last, it's my honor to take a good conclusion. We will tell everyone the 10 key points. The first one is in-depth understanding lung ultrasound based on lung anatomy and COVID-19 pathology. 2, in-depth understanding the lung injury of COVID-19, primary and secondary, both. And then the third, in-depth understanding the difference between the virus pneumonia and the bacterial pneumonia, and both can develop to the ARDS. 4, pay more attention to heart features in critical COVID-19 patients. And 5, early identify and evaluation of critical events, early thought and early stratification of COVID-19 patients. And 6, adhere to lung protective ventilation strategy based on using critical ultrasound. The 7, adhere to lung protective circulatory management strategy based on using critical ultrasonography. 8, combined with the shock in COVID-19 patients, critical ultrasound is mandatory. 9, ultrasound is mandatory during performing ECMO in critical COVID-19 patients. The last one, the 10, principle of critical ultrasonography protocol selection. It's target directed. It's based on clinical problem. That's all. Thank you. Thanks for everyone. Bye.
就直接答吗？
Thank Professor Wang Xiaoting for bringing us an excellent summary for our COVID course series. And here comes our Q&A session. There have been lots of questions from our audience. I will pick up some meaningful questions, read it, and ask one of my colleagues to answer it. So let's begin with the first question. How to use ultrasound to assess the cause of shock in COVID-19 patients and the treatment. So I will ask Professor Yin Wanhong to answer this question. Please, Professor Yin.
Okay, Dr. Zhu, I will try to answer this interesting question. If you followed the lecture before, you would find the answer in the third lecture about the acute circulation dysfunction. We assess the hemodynamic changes, including the volume mainly by the IVC and the right heart, the pump function by the left heart, and the tone of artery, which we call resistance. And when we have completed the assessment of the hemodynamic, we find the pathophysiological cause of shock. Then we would deduce the clinical cause of the pathophysiological changes. For example, in case of the patient with vasopressure, you would suspect the patient caught sepsis. Then the first thing you would do is to try to find the source of the infection. So if you find the pathophysiological cause of shock and the clinical etiology of the pathophysiological cause, you will know how to treat the patient. That's my answer. Dr. Zhu.
Thank you. So any other comments from our colleague? No? We'll move on. So the next question is, how sensitive is ultrasound to atelectasis in COVID-19 patients? So I will ask Professor Liu Lixia to answer it. Please, Professor Liu Lixia.
Okay, it's an interesting question. In terms of the anti-atelectasis, for the sensitivity of ultrasound, I think for the early anti-atelectasis, the ultrasound maybe is not sensitive enough. But for the later anti-atelectasis, there are several signs for the diagnosis of anti-atelectasis, such as consolidation. If you if you find a consolidation with R bronchogram, that maybe means it's anti-atelectasis. And if the lungs volume is reduced, maybe that means there's anti-atelectasis, such as you will see the heart shifted to the other side of the circuit of the anti-atelectasis zone, such as if the anti-atelectasis in the right lung, the heart will be shifted to the left, will shift to the right a little bit. That means that the lung volume is reduced. That is a sign of anti-atelectasis. But you should exclude the pleural effusion and other signs such as lung pulse and I think and the phrenic elevated. that all that are both the signs of the anaphylaxis. So I think maybe the anaphylaxis in the image of the ultrasound is not the direct one, exclude the lung pulse and the air bronchogram. But ultrasound, I think that will be some clues for us to make a diagnosis of anaphylaxis. That's all. Thank you.
Thank you. So any complementary comments from our colleagues? Professor Yin, Professor Wang? No? Okay, we'll move on. So the next question is, do you use any standard report for lung ultrasound? Actually, we don't have one standard report in our hospital, but I would like to ask Professor Ding Xin, how is your condition in Wuhan? Please, Professor Ding Xin.
Okay, just like Professor Zhu said that we don't have any standardized report for lung ultrasound. First, I have to say that we have mentioned for many times that you have to focus on different conditions and to use different protocols, such as if you do the lung ultrasound, you have to see what are you doing and what question do you want to ask. We say that is point of care ultrasound. And if you just want to find why patient have dyspnea or hypoxemia, maybe M-Blue protocol, just as we mentioned in our lessons, is enough. But if you want to see the distribution of B lines, and maybe you have to use the 8 rules or 12 rules, and that just to find how the B lines distribute and the locus on different parts of the lung. And if the patients are using prone ventilation, prone positioning ventilation, and that is very common in the COVID-19 associated ARDS patients, and you can't see the front line of the lung. So maybe Blue protocol, just you can do the ultrasound for the back of the lung when the patient are in the pro position, and that's another protocol. So you can find that we just mentioned you have to use different protocols for different conditions when you are applying the lung ultrasound. So we don't have any standardized report. But you have to remember that for every protocol, you just to find the standard pattern of the lung. That means A lines, B lines. B lines is divided into B7, B3, or the whole B. And you have to find that if the patient have consolidation or atelectasis, just as Professor Liu said that. And you find that if there are any pleural infusion and maybe sometimes subpleural consolidation. That's the standard pattern. So my answer is that we don't have any standard report, but we do have some standard pattern for the lung ultrasound.
Thank you, Professor Ding Xin. Yeah, I totally agree with you. And I think usually I like to use Blue or Blue protocol in my ICU patient, but for COVID-19 patients, since we all focused on interstitial syndrome of the lung ultrasound, so maybe it's depend on how we make detailed partition of the lung. So I don't know what kind of partition do you make for 28 or more than that partition? How many partition? 8?
You mean how many patients or how many areas or how many?
Yeah, areas, partition of the lungs.
Oh, we just use 8 or 12. 28 is 28 is just a big problem. And maybe if you want to see more of the lung, you can just rotate your probe. We often use the longitude and that's long to the perpendicular to the lung, to the ribs, and then you can just longitude perpendicular to the lung, and then just see, you can see extend the pleural line, and then you can see the area is more, and that maybe you don't have to do the 12-28 zoom method.
Okay, thank you. So any other opinions?
No.
No, okay, so move on. So the next question is, what is the value of central venous pressure ultrasound monitoring for clinical treatment in COVID-19? Actually, we have been asked several times in our Chinese and English webinar, and usually we would like Professor Yin Wanhu to answer this kind of question. Please, Professor Yin.
Yeah. This is a common question that everyone asks, and we have answered this question many times. And we know there are several studies focusing on measuring CVP by IVC assessment. The question is, what do we measure in IVC for? We know the diameter and the variety of IVC could tell us the fluid responsiveness and the hemodynamic of the right heart, to know the balance of the body temperature and the pressure of the right heart. So we can assess the right heart directly with the IVC and the shot and the septal of the right heart. So I think we do not have to translate the measuring of the IVC into CVP value to complete such a work. So we do not agree that there's a CVP ultrasound or CVP measuring ultrasound. You can just find the answer by assess IVC directly. You can just find the answer by assess the right heart directly. But if you still interested with the CVP value, you can get the accurate CVP value by the central line. So we always make us to clear about what we want and what we can get from this kind of assessment. So that's the answer. That is true.
Okay, thank you. So any other comments?
I have some comments. I think it's a good question. Maybe the Professor Ivan Hong answered the question is all the content of his answer is correct. I have some other comments for this question. Just like when you need a parameter to evaluation anything. So 1 meter plus other meter maybe indicate anything, any meanings of other. So I didn't agree with just like we every time we take ultrasound examination for the IVC. Every time you in your brain you think of the CVP. I want to tell everyone, IVC is very different from the CVP. If you need a CVP, I think you take a CVP monitoring for patients, and if you want get a IVC parameter, maybe you take ultrasound examination for patients. When you using IVC ultrasound parameter with the CVP parameter, maybe you can get lots of more information for patients. So I think it's very different. Thank you. That's all.
Okay, thank you. So we have other 2 questions, and the first is, what other organ damages can be seen with ultrasound for COVID-19 patients in addition to lungs? So I will ask Professor Zhang Lina, who has been working in Wuhan for several days. So please, Professor Zhang Lina.
Thank you, Dr. Zhu. I think it's a good question for the therapy for the COVID-19. We know this time COVID-19, the main pathology is the respiratory injury. So we pay more attention to the lung ultrasound. But at the same time, for the second organ damage, maybe the cardiac. We recently had published the article at the critical care found that the heart injury, we can do the echocardiography to find it. The main echocardiography feature of the COVID-19 pneumonia mainly have the 4 features. For the first, maybe we often see very common is the hypergemic cardiac function. And the second, maybe we can find the acute stress-induced cardiac emancipation. And the third, maybe the right ventricular enlargement and injury. Maybe some patients have the acute pulmonary hypertension. The last one is the diffused myocardial inhibition. When we for the therapy of the monitor the COVID-19, when we do the lung ultrasound, maybe must at the same time to do the echocardiography. For this is the together to help us to assessment the lung and the heart injury. And also we know that for the COVID-19 patient, except that we talk about the respiratory and the heart injury, we also can find that some patients have the AKI, maybe have the acute brain injury, and also the patient maybe sometimes to be the sepsis for the secondary infection. So for this time, we can also do the ultrasound. We know we can do from the head to toe. We can do the kidney ultrasound and the gastric and the intestinal ultrasound to find what's the underlying causing of the patient. We can also do the TCCD to find the blood flow and to help us to monitor the blood flow and to assessment with the blood pressure for the patient may be adapted to the patient. So I think that for the COVID-19 patient, there may be many other organ diagnosis in this kind of patient. When it's necessary to accept to do the lung and the cardiac ultrasound, when you necessary, you can do all the other organ ultrasound to help us to find the organ damage and also to find the underlying damage for the patient. That's all. Thank you.
Thank you, Professor Zhang Lina. I think we still need a lot of data of the ultrasound examination for other organs besides lung and heart from China and from all over the world. So we will see maybe in the next few months. So we have the last question. I think it is for Professor Chao Yengong, since he is an intensivist and he is an expert in tele-ICU or remote medicine. So the question is it necessary to apply remote medical diagnosis or AI in COVID-19 patient diagnosis and the treatment? So please, Professor Chao Yengong.
Okay, thank you, Dr. Zhu. I think it's a very good question. Yes, I have some experience on this area, focus on the remote patient monitoring and also the network ICUs. So if we answer this kind of a question, we have to focus on what is the most difficult problem in this situation. So, in this pandemic, I think the first thing for the whole world is the lack of resources. I think this is the first, not only for medical equipment sources and also the staff. So I think this is the first question. focus on how to use the remote view or remote monitor and try to organize your staff, your resource to help our patients. I think it's a first priority. So it's my answer.
Thank you, Professor Cao Yangong. I think time is limited today, and we have to call it an end. And you know, this is our last webinar, and we would like Professor Wang Xiaoting, tonight's speaker and also our chair of CCUSG, to give us a simple summary for the whole COVID-19 management courses. So please, Professor Wang Xiaoting.
Oh, thank you. I'm the co-chair. The other chair is Professor Cao Yangong. Hi. First of all, I would like to say thanks to everybody online, and to say thanks to our every colleagues from CCUSG, Chinese Critical Care Ultrasound Study Group. And I would like to say thanks to support staff and to sponsor company, Mindray company. And then I think I want to say thanks to every colleagues again. We take a month, maybe more than a month, to prepare our course. Almost almost all of our speaker come from frontier of fighting virus. So the course tell us critical ultrasound is practicable and feasible. So lots of our colleagues, maybe Lina, Wang Hong, maybe Ding Xin, Cai Shuhan, it's work hard for a long time to fight the virus. So I think thank you for your hard effort. And then I want to say, I hope our course may have good impact on the practice of the fighting for the clinician, for the practitioner in the frontier of fighting virus. And I think there's a famous scene, just like what I mentioned in the very beginning of my lecture. This famous scene come from Prime Minister of